Morning and welcome to the Fujifilm Symposium, Lunch Symposium on Open MRI. It's a great pleasure and honor for me to open this symposium and welcome you here. My name is Luigi Lunetta. I am head of MRCT business in Europe for Fujifilm. I have to say that our company started investing and brought the first open MRI in the market since more than 30 years ago. And since then, we have continued developing this technology, bringing to healthcare professionals and to radiology operational the utmost improvement that we could in our possibilities. So we kept on developing our systems and regularly introduced novelties and new performances to our MRI open system portfolio. The development grew up to today where we have the only unique system, eye field, in the market, which is our actual flagship product, which encompasses all the technology, all the sequences that we can operate with an MRI scanner. Today we will have prominent speakers who will tell us and share with us what their experience is working with open MRIs and vertical field machines. At the end of this symposium, you can pass by our Fujifilm booth to meet the speakers, to have eventually pictures and to profit of an important gift that we are ready to give to all of you, which is one of the latest publication of Professor Shellock. Once again, thank you very much for being here with us, and now I leave the floor to Dr. Biederer. Thank you.
Thank you very much. Yeah, great to see you today for this workshop on the conference on Open MRI. Well, may I kindly ask you to switch off your mobile phones and now focus on 3 talks. We've changed the order a little bit, as you could see here, so it will be me starting off with Open MRI, more than just a question of comfort. Then we will hear more from the practical work from Dr. Aradi from Hungary. And finally, we will discuss about safely managing patients with passive implants on vertical field scanners. Well, let me start again with this beautiful lady in a beautiful setting. My conflicts of interest disclosure. And there we go. Let's look at MR from a patient's perspective. High-tech medicine, but not at all a pleasant experience. We tend to forget what our patients may feel, suffer, or expect from the examination that we are doing. It's a long, loud procedure in a narrow tunnel, typically. There are some fixating devices. There's a head coil or something which sort of keeps the patient in a certain position. They feel alone and exposed. A needle will be placed for contrast injection. Don't forget, many of us, maybe you included, do not like injections. And patients are typically far away from really understanding what is happening. When talking about MRI, there are different dimensions. There's the comfort dimension for the patients. There's also the dimension beyond comfort. This is the clinical needs, what you would expect from the examination. Also, performance, specs you would expect from a high-end scanner. And last but not least, things need to be bought. You need to know the right facts to convince your paymasters. So this is the field in which we are moving in. Patient perspective, clinical needs, expectations on performance, and economic perspective. Let's start what should always come first, the patient. What would patients want? A pleasant setting. This is convincing, I would say. It's a nice light room with wonderful displays on the roof, on the walls. A nice bright room, pleasant setting. Check. A spacey open system, no tunnel. People hate tunnels. So this is a spacey open system. Again, we see our beautiful lady just stretching the arms, and you can see how spacey the whole thing is, how much space this gives to the patient. Comfortable positioning Don't forget, not every patient can lie on the back or in a sort of fixed position, so it can be very comfortable to be positioned, for example, on the side, and this requires a setting. So this means they don't look at the roof of the scanner, they look to the side, and this is what they would see. They look at the beautiful landscape at the German Northern Sea. And how can this be done? You need a coil which is flexible. This is the multipurpose solenoid coil. It's just a solenoid, and you can do, well, perfect images with this. Just an example of a cervical spine, or example of a brain examination with a solenoid coil, patient lying on the side, comfortably looking at the beautiful landscape. All the setting is very, very comfortable and very pleasing the patient. Even if you're only using a solenoid coil, which is a sort of a basic coil setting, you can do excellent, for example, time of flight MRIs in this setting. Less noise is what patients would expect. So your ideal system, if there was one, would offer noise-reduced scanning. There you are. It's integrated in this system configuration. A short procedure would be wanted. Of course, the shorter the better. Fast scanning, so this is a brain scan done in less than 10 minutes, and you simply have it all. You have a T2 weighted, T1 weighted standard images, you have a flare, a T2 star weighted, susceptibility weighted imaging, it's a terrible word, diffusion weighted, and you have the time of flight. So all done in 10 minutes. So this is also something, a point of comfort, an aspect of comfort for the patients. And then they would want you to have, not to inject, not to put a needle into them. A very simple but understandable wish. So great carotid angiograms here done with arterial spin labeling and not a trace of contrast injected. No needle. Okay, patients will love it. But beyond comfort, there are clinical needs. Clinical needs, in particular, you need a solution for claustrophobic patients. Don't forget, claustrophobic are patients who sort of have a problem with difficult situations. Just think about the demographics, just think about people with dementia. The more quiet, the more pleasant the thing is, the easier it will be to do the examination. So an open design, no tunnel experience, and having a person at the patient's side, that helps a lot. Also, accommodation of large patients. Imagine your open scanner will attract patients who are not easy to handle, like the one in this row. You need to be a bit, of course, flexible. You need to be a bit sort of smart to solve the problem. For example, like this knee. There's a wonderful examination of the knee, but there's a lot of patient around this knee. And, well, it will not fit into a standard knee coil. So you can use, for example, this blanket coil, which is very useful. You just wrap it around, and you get a very nice image of the knee with a lot of signal and all the important structures, which can be very well discriminated in this image. Also, you would need a solution for large patients when you go for the spine. So this is a very large patient. This is lumbar stenosis. And there is a particular advantage of this vertical field scanner that you have a lot of signal even deep inside the patient. As you could see it here. Perfect image quality, and you see there's a lot of patient around this spine. And, well, some situations need creativity. This is a very cute one. That was the example of a very small child, almost newborn, that should get an examination of the brain. What you see on the left is from the scout. You see the breastfeeding of the little child. You can put the mother inside and the child inside, do breastfeeding, and then the child relaxes and you can do your examination. Just imagine that in a standard tunnel system. Not possible. So you see the brain of the child here. You see the hand of the mother, the fingers here. And a bit more on this image, you can see how the child is held by the mother during the examination. Isn't that cute? And you can do the examination. Also, clinical needs. Some positioning options may be very useful, in particular in the MSK. If you do a shoulder in ABER position, you can see what is done in the ABR position. So there will be a torsion force to the bicipital anchor, and there will be a peel back of the tibiolateral tear, which will make it much easier for you to distinguish kinds of ruptures, and very easy to position the patient in this sort of bit awkward position. That's the difference between standard and ABR position. Here you see how it is, and a clinical example from the literature where you can nicely see how this peels off and put a force to the labrum, and you can much easier detect a labral tear. Another lovely one. What we love with the tunnel systems, a critical thing, is to put an elbow into the isocenter. It's a bit acrobatic sometimes. You just put the patient on the table, and there's one great thing. You can shift the table to the isocenter. Just put the patient in a convenient position, and you can do this kind of examination. So this is a wrist call in this case, but I will show you an example of the elbow now. Now you can see the elbow in the isocenter, and you can, of course, nicely see how here you see the epicondylitis and excellent image quality, I would say. Other needs raise from metal implants. Well, the size and shape of the artifacts, you would say, changes with the angle to the direction of the magnetic field. As you can see it here, there's a certain magnetic field, and you change the direction of the screw, and it really sort of turns out in weird artifacts. These artifacts increase with the angle. So in the vertical field that they're using here in this scanner, many materials are already favorably positioned, or you have the space to position the patient favorably. Like here, you see the instrumentation of this low lumbar spine. You can nicely see the screws and excellently discriminate the structures around because they're in the right direction. If they were not, you could simply turn the patient, like it was done here. An example of 2 screws after tibial fracture. Just turning the patient around minimizes the artifacts and significantly improves image quality. All this liberty you would have with such an open system. Well, you would say an open system, there are a lot of compromises to accept. Well, expectations on performance, I think they should meet your criteria. With a 1.2 Tesla vertical field, very homogeneous. It's a superconducting helium-cooled system, 33 millitesla per meter, 100 Tesla per meter per second rise time, acoustic noise reduction, high-order shim system for spectral fat saturation, parallel imaging, sparse sampling, iterative reconstruction, all the package called IP Rapid. All is in there, motion correction, and a table that would really accommodate large patients. 300 kilogram is quite a bit, I would say. You could also do what you would expect from a scanner in that Tesla range. You can do T2 mapping of liver fat. Here we see a healthy liver on the top and the steatosis on the bottom, or T2 mapping of the knee cartilage. All this works with such a scanner. Prostate, multiparametric imaging, everything you would need for full coverage of Pirates criteria at excellent quality. So this does not look like a compromise. This looks like excellent images. Nice. But how about finances? Well, let's look at the typical use case. The use case of Groß-Gerau County Hospital. Well, Groß-Gerau County Hospital, not so many people of you would know it, but most of you have probably already seen it. If you come into Frankfurt with a plane, you would see it on your right-hand side, because it's very close to the airport. It's a county capital. There is Frankfurt around, Mainz, Wiesbaden, Ludwigshafen, Mannheim, Heidelberg. But it's a county capital in the middle of it all. It dates back to a Roman castellum, has a 26,000 people population, young growing population. It's in the Rhine-Mecca metropolitan regions. Frankfurt Airport is around. And the most important point I would say about Groß-Gerau is the county hospital. People may differ in this opinion. Well, the idea is, the rationally, the hospital is a small fish among many big fish. It needed a new MR system, enough high-end scanners in the region, whatever enough would mean, but there's a lot around, not just counting the university hospitals, also private practices. Something unique is wanted. You want to do something unique, something specific. So, and you want to extract additional external patient to make the whole thing profitable. So, let's take a system that the patients would want, and not only the patients. From what I've been talking to you so far, this system would fulfill everything you would expect from a patient perspective: pleasant setting, spacey open system, no tunnel, comfortable positioning, less noise, no injection. Lovely. Clinical needs, yes, you could accommodate claustrophobic patients, large patients, pediatric, and you have all the positioning options if you have to deal with metal artifacts. Expectations on performance, yes, it's high field with strong gradients and all options for the advanced procedures. Finally, the economic perspectives. Well, you would expect less examinations to be aborted, procedure times shortened, new patients attracted, and opportunity costs reduced. Let's have a closer look on that. What is the problem? That's the last big obstacle. It's a county hospital. This means you need public procurement procedures. You can't just go and buy it. You have to explain why exactly this system. And in these typical procurement procedures, performance and price as main criteria, almost the sole criteria. A higher price for a specific system configuration must be justified. Soft criteria such as social, psychologic, ecologic, patient perspective are usually not accepted, not in these systematics, unless you can show that additional income or savings can be realized. Something like additional income from attracting new patients or reducing opportunity costs. And it's very interesting with a greeting from my colleague, Professor Dr. Raab from Groß-Gerau. She had a closer look at this, and she managed to buy this system for Groß-Gerau. It needs a sort of value-based versus price-oriented procurement thinking. It's extended cost controlling beyond just purchasing the machine and servicing it. It includes savings for the hospital from less cancellations and abortions of examinations. It includes additional income for the hospital, while there are, in the German system in particular, extra fees for handling large patients, which could not go to other sites. There are extra budgetary fees for handling claustrophobic patients and also attraction of private patients. For those, comfort and the setting would be important. Let's take an example for the cost-saving aspect. The example, a road accident victim, spine fractures, an MRI was required, and the examination was tried 2 times in a classic tunnel system, aborted for panic and pain. So the patient had to be transferred to a hospital with an open scanner. What does it mean to our hospital? Well, there will be the cost of 1 day without treatment, 460. The cost of the aborted MRI scan, minus 650. Shortened flat rate because the patient was transferred to another hospital, there's a penalty. So of the already small flat rate of 1,700 euros, only 60 euros were left for the hospital. Compared to the full flat B, if the patient could have stayed in hospital, if he could have had surgery, everything done. So opportunity costs, missed changes of 5,840 euros. Stop, you would say. This is just turnover. This is not revenue. The interesting thing about opportunity costs is, and this is what we have to see, you have to compare it to this situation because this is money you don't get, although everything is already paid. It's like a tram. You have paid the tram, you pay the electricity, you pay the driver, you pay everything, and you leave 10 passengers behind at a stop. This means full costs, but 10 tickets of 2.50 euros not sold. This means 25 euros opportunity costs. And that's the interesting point. You are working in a system where everything is already paid, and every single turnover on top counts almost equal to profit. And this makes the whole calculation very interesting. So the system was bought, and this is the result. 112 of the first 250 patients were claustrophobic, and not a single examination in these was aborted. There was a drastic reduction of related opportunity costs, and additional external patients were attracted. Recommendation rate from the patients after the examination was 98% after 3 months. Thank you for your attention with this wonderful view on the German North Sea beach. Yeah, thank you very much. We will have probably some minutes for questions later. I would like to continue now with Dr. Aradi from Hungary. He is working also, and he's a very nice setting because he has all kinds of systems and an open 0.4 Tesla in between, and I hope he can confirm our good experiences. Thank you very much.
Thank you for the introduction. I'm honored to be here among such speakers and professors. So we heard about the top of the open systems. Now it was really the Maybach. Now I'm going to talk about more the an affordable version. the low-field scanners and how it can perform in the clinical routine. Just a few words about me. I'm a doctor. I started out with a PhD in MRI, and there I was infected with operator-level experience. So I'm a bit special because I spend 2 days a week also working as an operator and doing the special hard examinations, just like making an ultrasound. And I can also write the report because for 7 years I've been also a radiologist. I work in Hungary at a fully private center. Now I'm totally in the private part. It covers my whole time. I'm the chief radiologist. We have been using an open 0.4 Tesla system for 9 years, and we started out with that machine, and it was a really good choice for us because in the beginning we didn't have much patients, and in Hungary the private sector is very in the basic state even now. So the NHS doesn't fund anything in the private system, and the private contractors are very scarce. So we have to pull patients from the street really by paying the full examination fee. But we managed with the 0.4 Tesla, and we even managed to expand. Now we could buy a 3 Tesla Siemens Skyra. Actually, at that time, Fujifilm or Hitachi, it was that time they didn't have in Europe 3 Tesla, so we went with the Siemens. And but we also still have the Aperto. I just wanted to show you that the lower systems are really good for making a start where you can secure your financial background, and then you can expand further on. So what brings us here? That there's a big financial diagnostic pressure in the 21st century medicine. The expanding knowledge needs imaging, and actually one of the best imaging now is MRI. The biggest problem is that it's expensive. Okay, I'm speaking from Hungary. We are a poorer country, but we are not flooded with high-field scanners as in Germany or in the US. But I don't think that they have enough machines there. And as the new turn of events in the international state is going, now the very rising of the electrical bills makes a totally new perspective for the scanners. So more MRI machines are needed. How can you buy an MRI machine? You have to really match your possibilities with the needs of the place you try to cover. If you are not matching perfectly, you can easily go bankrupt because these are very expensive machines and the bills are really high. So you have to plan accordingly. What I will now speak about is the open 0.4 Tesla system feasibility. So what can such system offer for somebody who is looking for an MRI? It's a permanent magnet, which is really good because it doesn't need any helium or water cooling. It's a bit heavy, but its heaviness doesn't cost anything, only in the beginning. So for the running costs, it has really low running costs. And also it has very low installation and maintenance needs. So you can put it in a small place. You don't have to build a new compound. And what I looked up from the internet, and I can confirm it from our experience, maybe it's even higher, that the electricity bill of such machine is really a fraction, so about 1/10 or even more of a superconductive system. So our 3 Tesla Skyra consumes, I think, even more than this. And it's very comfortable. It's a 32-degree open system, so not like the Oasis, which is a 2-pillar. This is a 1-pillar system. It has a really low noise, and the same motorized, also laterally movable patient table. So really you can put the joints in the ISO center, also the shoulder, during the examinations. And as for the image quality, I will speak more in my presentation, but a few words that it's working because it has a really good advanced signal processing that has been updated lately. Sadly, we don't yet have this upgrade, but we are really looking forward for it, because what I will show you images are from the older system, which does not have this upgrade, but we were really satisfied with that also. Just a few words about the passive MR physical consequences of a low field system. The alarm frequency is much lower, so it's around 70 megahertz compared to a 3 Tesla system, 120 megahertz, which as a radiologist, you can imagine if you are using an ultrasound, that if you change from the 5 megahertz head to the 15, that you can only look 2 centimeters deep instead of 20 centimeters into the tissues. Of course, it's different phenomena because ultrasound and the electrical radiation is different, but the phenomena is the same. So plenty of things are different. You don't need that much power because it can penetrate much easily the body. This means it's much cheaper and much lower electromagnetic field radiation has to be used. So the SIR level is much lower, which is an unsolved problem still, as far as I know, in the EU. So it's always postponed to get. I think the regulation is an old one, and it hasn't been yet solved. But for this machine, it's no problem. And also because of the lower frequency, the fat-water frequency difference is not that big. And by having the same amount of frequency encoding gradients, it's the blurring between the fat and the water is much lower, so images are sharper. You have a lower susceptibility artifact. This is good for the implants, which will Professor Shellock speak after me. And the T1 contrast, actually it's an MRI phenomena, is better because the T1 relaxation is faster. And on the contrary, the T2 contrast is worse. So you have to adjust the T2 contrast with a bit longer echo time. What is non-beneficial is and what everybody knows about the low field scanners, that the raw SNR, so the signal to noise ratio, is low. And this is why these machines were not used, because everybody was afraid that it cannot be used for imaging. However, new signal processing techniques made it available to be used properly. And nowadays, routine imaging is really accessible with it. It does need a bit longer measurement times. However, with the new Lucent Plus upgrade, it has been reduced, as far as I know, into the vicinity of the 1.5 Tesla systems. And just to summarize one point with the 0.4 Tesla, it's less forgiving, also because of the SNR. So you have to be, as a radiologist and technologist, much more prepared for it, because on the 3 Tesla, if you are not doing things properly, then you can still have somehow good image. But on this machine, you have to be prepared and know your machine accordingly. So how does our 0.4 Tesla system perform in the practice? And is there really any image quality benefit on the low field compared to the high fields? This is the answers I try to, this is the questions I try to answer with my images. I just show you 2 images. These are the same patients. Actually, I found them during my practice to come back from different systems. So what do you think? Which one is a 1.4 Tesla? 1.5 Tesla, which one is the 0.4 Tesla? Okay. So if you look at the images, I think we can say that it's very hard to differentiate. So this is why we bought a 3 Tesla machine after a 0.4 Tesla, because with a 1.5 Tesla system, we wouldn't be much ahead. And as you can see, that even before the other cases I will show, that it's really on par with the 1.5 Tesla systems. So as for the brain imaging, we managed to set up a 5 millimeter gapless protocol. It's around 20 minutes. And as you can see, it's totally good routine imaging. Of course, it's it cannot compete with special advanced neuroimaging applications like functional MRI and DTI, but this machine is built for the routine. So we really have also DVI, TOF, phase contrast, and actually the T1 contrast, as you can see, is really good even on a single turbospin echo image. So just a clinical case, a meningioma. This is a 3D T1 we managed to set up on the machine. Just like on the bigger machines, it's a bit thicker. It's 1.5 millimeters the slice thickness, but around 1 millimeter the other dimension. So as you can see, even in reconstructed axial slice, that it's a really good resolution, and the good T1 contrast allows us to have a good enhancement pattern. And also on the native images, you can very well realize that there is an expanding tumor on the skull base. Another neurological case is a cystic astrocytoma. I just wanted to show you the clinical practice that it's really working. So here, the same 3D T1 image, 3D reconstruction, sagittal, axial. Actually, the 3D measurement is done in the coronal plane. And you can see that even on the DVI is usable because the cystic part can be well detected on the DVI images. And I think it's totally up to the mark what I would expect from a routine imaging machine. So here I have another clinical case just to see that it's really can be used for neuro, like a stroke. Actually, it's a subacute stroke because the T2 images, there are still also T2 hyperintensity, but we still have on the ADC map the lower ADC value, which shows that there is still diffusion restriction, and it's not a T2 shine through on the DVI. And another, I think, what we wouldn't expect from a point for Tesla system, another example is that to be able to visualize the auditory nerves, but this is a native image. It's a small slab 3D T1. I think it's also around 1 millimeter thickness, and this is a 3D T2, but as you can see, you can even see on the native images the auditory nerves. And here an acoustic schwannoma, where you can really see that how good it's working. Even the small cysts can be differentiated. And also the routine images are very diagnostic because you can, without the high resolution inner ear 3D T1, you can still see the acoustic neurinoma. So as we're moving further, I brought you a case of a small child. He was 4-year-old, and it really shows that on these machines with the comfortable environment and the silent gradients, children are more calm. So we managed to do this without any, so it was an awake examination, so no anesthesia is needed. And by using these radar measurements, which is, if you are using other machines like Blade and so on, this is something like a motion less sensitive measurement. This 4-year-old child could be, we were able to examine, and as you can see, he had a retropharyngeal abscess, and we even managed to do DVI, where you can see the pus diffusion restriction here in the lowest image. And the 4-year-old child is a small one, so it's really putting the machine to its edge. But as you can see, its resolving power is really good because even with these small voxel sizes, you still have enough signal. It's another child case. It's another hard to examine part of the body is the ankle and the tibia. It's a 9-year-old child with a non-ossifying fibroma, and you can see on these images that the cortical sclerotic lining can be differentiated very well, and also you can see the talofibural ligament very easily, and you can really, so it can really resolve this resolution to be able to make good reports and good diagnosis for such complicated and child cases. And I don't have much time to show you joints, but the machine is really good for joints. Just a few images, a knee, also the wrist and the shoulder. Actually, it's a supraspinatal tear. And I can tell you, by putting the joints into the isocenter and having the dedicated coils, so our trick is always to give the machine what it needs. You have to buy the dedicated coils, and also on the free Tesla system, I have to tell you. So in Hungary, we are the only one to have the fully equipped machine for the free Tesla also, because people don't buy it. So if you buy the wrist coil, then you can really do high resolution imaging also on the 0.4 Tesla system, and also the shoulder coil allows us to do nice images of the shoulder. From the abdominal and pelvic area, I just brought one case just to demonstrate that you can use this machine really for whatever you need. Is a rectal gel distension for staging a rectal cancer. Actually, at that time, we didn't have the free Tesla, but we had the clinical questions, and we really tried to live up to the mark. And I think we succeeded with these examinations, because here you can really see the rectal cancer stenotizing the rectal canal, and also the enhancement on the fat set images, and also the stir image really shows that you can use it really well for high quality radiological work. And by reaching the end of my presentation, I just want to show you why is it really good to have a 0.4 Tesla system even nowadays that we have the 3 Tesla. It's a very sad case, but a very demonstrative. Young guy, very big build, and actually he was really good looking. He was a carpenter, fell from a big height, and he broke his spine. And for months he couldn't move. He was paraplegic, couldn't move. And he just came to us and asked whether we can do anything to say what's the problem. And we put him into the 3 Tesla system, and with all the knowledge that I have to reuse the metal artifacts, I could produce only this image. And then I said that, okay, let's put him into the 0.4 Tesla system. And as you can see that, so this is the difference between the high field and the low field regarding to the metal artifacts. That here on these slides, these images, I just want to show you that you see the metal which doesn't have any water in it, so it appears as no signal. But you even see the screw and everything, the foraminals can be discerned, and you see that the myelin is compressed, and he won't be able to walk this way because the myelin is so compressed that it cannot recover. And one more implant just to connect to the next presentation. It's a proximal femoral nail, and around the proximal femoral nail an abscess was the question, and you can follow the fistula back to the side of the nail. Actually, we was able to do DVI also to confirm the pus, but the pus was coming from the fistula, so it was not a matter of question. But as you can see, you can really use the machine to image problems around the implants with this quality. Also, it's the axial view. So, sadly, I had only this much time. I hope I could really show you how we use the 0.4 Tesla system in our clinical setting. All of the images were our images from the Hungary private clinic. And to summarize some take-home message from my presentation, I can tell you that the 0.4 Tesla Hopsital can give you a feasibility of a low running cost with high patient comfort, in high-quality routine imaging. So this is, as you could see, this is for the routine imaging, but the routine imaging can be performed even on this previous Lucent, because the Lucent Plus is even better. And the benefit of the low field system is the metal implant imaging, and this is an extra what you get with it. So if you are searching for an MRI, and you can use these parameters to match your needs. And thank you for your attention.
Yeah, dear Dr. Aradi, thank you very much for this wonderful insight into your direct clinical work with such kind of systems. We keep the questions for the very last minute. So it's my pleasure now to announce Professor Frank Shellock from University of South California in Los Angeles, and he will deepen now the insight into the whole story about metal implants. And I think he has dedicated his scientific life to this. And it will be a pleasure to listen to your talk.
Thank you very much. It's a pleasure to be here at the European Congress of Radiology 2023 in Vienna. Love it. So I'm going to talk to you today about safely managing patients with passive implants on vertical field MR systems. And I'm going to cover the various types of vertical MR systems that exist. I'm going to explain the aspects of passive implants with respect to the testing and labeling of these devices. I'm going to cover the MRI-related issues that exist for passive implants and devices. And I'm going to provide guidelines for managing patients with unlabeled passive implants, as well as guidelines for patients with untested passive implants. So if you look at this slide, you'll notice that there are a wide range of vertical bore systems. These systems exist throughout the world. They come from a variety of companies that are worldwide. They operate anywhere from 0.2 Tesla up to 1.2 Tesla. I'm going to confine my comments to the whole body MR systems that exist in the realm of vertical bore scanners, but realize that there are niche systems that are used for imaging the brain, or dedicated extremity systems that are also available on a commercial basis. One of the things I also wanted to show you on this slide is that there are very different configurations depending on the manufacturer and the design needs for these vertical bore scanners. So you've already heard from my colleagues that there are a wide range of advantages, proposed advantages for vertical bore MR systems, and that includes the aspect of improved patient comfort, which reduces the possibility of motion artifacts. You can accommodate physically large or morbidly obese patients. It's a great way to manage claustrophobic or patients with medical test anxiety, where the individual can simply move his or her head from one side to the other and see outside the MR system, which is not possible for scanners that have a closed bore or a different type of architecture, which are the standard high-field scanners. It also permits the lateral or centralized positioning of anatomy into the sweet spot, if you will, of the MR system, improving image quality. And it can be used for MR-guided or intraoperative imaging procedures, which are growing in popularity. So there's a lot of possible advantages that these systems have because of their open architecture. As all of you well know, the standard of care is before a patient goes into an MRI system, they have to go through a rigorous screening procedure, and that is vital in order to ensure their patient safety. And if you don't do that, you can have a serious problem occurring. During the screening procedure, the MR safety trained healthcare professional uses a written form and does a verbal interview. And one of the most important aspects of that interview is to identify implants or devices, metallic implants, that might exist in the patient, because if you don't do that, you can have a catastrophic event, and that includes a serious injury or a fatality. During that screening procedure, if you identify a medical implant, the procedure then is to look up the information on the company's website, the implant manufacturer's website, or you can go to my website, mrisafety.com, and find out if that implant, in fact, was tested and if it was labeled for the MRI procedure to determine if it is safe to scan patients under those circumstances. And this is what typically happens if you have a passive implants, and passive implants are those that exist without any type of electronics or power source associated with them. These passive implants include things like orthopedic implants, heart valve prostheses, vascular stents, and anything within the area that does not have a power source. So again, confining my comments to passive implants, the implant manufacturer either tests these implants in-house or they send them to a test house such as my company, MRISafety.com, Shellock R&D Services. And our group has tested thousands of implants since I started doing MRI safety work back in 1985. Suffice to say, though, that once the passive implant is assessed for force, torque, MRI-related heating, and characterizing artifacts, that information then gets submitted to a regulatory body. In the US, it's the Food and Drug Administration. In the EU, we have the EMA or other regulatory body. That information is reviewed by the notified body, and if it's found acceptable, the information is then presented in the instructions for use for the implant. And what you'll see there is highly specific information that the MRI technologist in turn, or the radiographer, reviews and determine if they can meet those conditions in order to scan the patient. And what exists in the instructions for use is a term that's applied to the implant based on the test results. Either it's MR safe, MR conditional, or MR unsafe. An implant that is made out of a non-metallic and non-conductive material is termed MR safe, and that means it's safe under all MRI conditions, whether you're imaging at 7 Tesla or all the way down to 0.064 Tesla, which is the range of scanners that we have in the clinical setting. It's safe under all MRI conditions. Or if it's MR unsafe, it can pose a hazard or risk or something serious to the patient in the MRI setting. So those are MR unsafe things such as a ferromagnetic pair of scissors, or let's say a neuromodulation system that might pose a hazard because of heating or inadvertent stimulation. The bulk of the MR conditional labeled implants are passive implants. And these are implants that pose no hazards in specified MRI environments. So the labeling will have highly specific information with regard to the static magnetic field that's acceptable, the spatial gradient magnetic field that's acceptable, and the RF field level that is acceptable for the patient to ensure safety. The problem exists that few, if any, implants that have been tested for MRI-related issues exist in the area of vertical bore scanners. Vertical bore MR systems have possible and highly specific issues associated with them. First of all, there's consideration that must be given to the force and torque with respect to the field strength, imaging at 0.2 Tesla or all the way up to 1.2 Tesla, and also, more importantly, the direction of the static magnetic field relative to the implant is in a different orientation. Depending on the position of the patient, it's either in an anterior-posterior position or a left-right position. So the direction of the static magnetic field is inherently different. You can have MRI-related heating. The MRI-related heating tends to occur in something with an elongated shape or that forms a closed conducting loop of a certain diameter. And it's specific to the frequency that you're transmitting RF energy at, and it's 42 megahertz per 1 Tesla. There's been a body of literature in the MR area that states that you can have greater heating at lower frequencies, and that is really specific to conventional MR systems, so horizontal bore systems. The information that exists for vertical field scanners is substantially different. And the reason is because the direction of the E fields are different. They're perpendicular typically for an implant, which results in lower temperature rises. And this has been reported for both passive and active implants. It's an important distinction that exists for vertical bore scanners. Similar to conventional MR systems, if the device has an operational or a functional component, you can have disruption of that device. And for example, things like programmable CSF shunt valves, or there are certain orthopedic implants that exist that have magnetic programming associated with them. For example, magnetically activated distraction rods that are used to treat scoliosis. And then finally, while it can be argued that it's not exactly an MRI safety issue, the artifacts are substantially lower at lower fields. So going from 1.5 to 1.2 or even lower, you will typically have lower artifact signal loss related to a metallic implant that might be present in a patient. So those are the possible issues that exist for passive implants. Now, let's look at what the issues are for these devices, these passive implants. If you look at the instructions for use or the operator's manual, per se, from the vertical scanner manufacturers, it will typically state, and this is by law, a regulatory aspect of it, that the manufacturer cannot tell you how or why you can scan patients with unlabeled metallic implants. They simply tell you, follow the instructions for use for that particular passive implant, which is problematic because few, if any, implants have ever been tested and specifically labeled for a scanner that's operating less than 1.5 Tesla. Possible exceptions are a couple of the older cochlear implants that were labeled at 0.2 or 0.3 Tesla years and years ago, and few patients even have those cochlear implants anymore. And anything that's labeled for scanning is typically refers to a horizontal bore scanner. You may actually see that in the labeling where it'll say 1.5 Tesla and or 3 Tesla, horizontal bore scanner only. So highly specific information exists in the MR conditional labeling. Certain implants that might exist that have labeling that says it's okay to scan the patient at 1.5 and or a 3 Tesla or less really assumes that you're scanning with a horizontal bore scanner, not a vertical bore scanner. And from my interactions with implant manufacturers of all types, even those that have active implants like cardiac pacemakers, neuromodulation systems, and of course passive implants, the implant manufacturers do not tend to be interested in testing and labeling their implants at anything other than 1.5 or 3 Tesla. If no labeling exists, and because of the facilities policy, and that tends to be the standard of care with our MRI systems that are operating throughout the world, the policy is if you don't have labeling specific to that implant, the patient may be refused the MRI exam. The exception is if the supervising physician has an understanding of the issues that I presented for a particular scanner and the vertical bore scanner in particular, they can override that policy and they can make a decision on a case-by-case basis. So those are really the things that are of concern when you have patients that present for MRI exams on vertical bore systems. If you look at our American College of Radiology's manual on MR safety, there's a statement in there that basically states that the final determinant of whether or not to scan a patient is to be made by a level 2 MR physician responsible for the patient or the MR-MD. That's a specific term that's referred to in the manual from the American College of Radiology. What a level 2 MR trained physician is an individual that has the body of knowledge and the understanding of all the safety issues that might exist in the area of MRI technology. And that means including the information that I presented to you with respect to the possible issues that could present themselves for passive implants and vertical bore MR system usage. So what do we do as far as scanning patients when they present with the large number of passive implants that have never been existed and have never been labeled specifically for use in the vertical bore area? Well, what can be done is that the MR-trained healthcare professional, that supervising physician, can determine on a case-by-case basis the associated risks and the benefit of the MRI exam for that individual. And again, that supervising physician should have an understanding of all the MRI-related issues that can impact passive implants. It is not very cost-effective or time-effective or efficient for a supervising physician to have to make a decision for a patient on a case-by-case basis. And so what I am here to propose to you, and what has been done at MRI facilities throughout the world, is that general policies are implemented. These are written policies and procedures that are in place at these MRI facilities where the supervising radiologist has approved this type of a policy, that it's acceptable to scan patients with all passive implants that have labeling at 1.5 and or 3 Tesla or less. And with that general policy in place, you can effectively scan patients with all of the thousands of implants that have been tested and labeled at 1.5 and or 3 Tesla. And that would allow you to effectively utilize all the proposed advantages of vertical bore systems operating from 1.2 and down to 0.2 Tesla. So this is a policy that can be implemented and it can be utilized on a widespread basis. What do you do, however, when you have a patient that has an untested passive implant? So this can happen in many instances. For example, a lot of orthopedic implants, which represent some of the largest metallic objects that are implanted in patients, do not have any testing or labeling whatsoever. So that can be done on a case-by-case basis by the supervising physician with their understanding and appreciation of those previously named possible issues that exist for passive implants. Consideration must be specifically given to the field strength and, of course, the frequency. Field strength and direction of the magnetic field with a vertical bore system. The transmit frequency, is that at a level that is associated with a 1.2 Tesla scanner or a 0.2 Tesla scanner. Keep it in mind that the direction of the E fields will result in a lower temperature rise. You can also then afford a larger margin of safety if there's any possible concern for MRI-related heating of an untested, unlabeled passive implant by scanning the patient in the normal operating mode that defaults the whole body average SAR level to 2 watts per kilogram. And then finally, if the implant has some functional aspect or operational aspect associated with it, further consideration must be given to that as well. Let's just look at an example of an untested, unlabeled passive implant. These are total hip prostheses, bilateral devices. Hip prostheses, these are made out of cobalt chrome stems. They have ceramic femoral heads and titanium acetabular cups. There's a request for an MRI exam of the lumbar spine, and you have a vertical bore system operating at 1.2 Tesla. Keep in mind, what do we need to consider? Field strength, 1.2 Tesla. What is the issue that might occur for this cobalt chrome ceramic femoral head and titanium acetabular cups? Little or no magnetic field interactions exist. Almost no torque and almost no deflection or force associated with these materials because they have low magnetic susceptibility. So that will not pose a hazard to the patient. What about MRI-related heating? Well, I mentioned that things that have elongated shape could potentially heat under MRI conditions. There's elongated shape there. But keep in mind that for implants that have a large surface area, like these orthopedic implants, the heat will not significantly be generated in these total hip prostheses. So even at 1.2 Tesla, transmitting at approximately 50 megahertz, you're not going to have substantial heating. These don't have operational aspects, so possible disruption does not exist. So I could clearly state that it would be acceptable to scan a patient's lumbar spine with a patient that has these bilateral hip prostheses, and an example that exists for an implant that's been untested and unlabeled for MRI. So I have the value of being in an audience that obviously has interest in vertical bore MR systems. And just by show of hands, how many of you are actually utilizing a vertical bore MR system presently in your clinical setting? Okay, and how many of you will actually scan patients with unlabeled implants or untested implants on the vertical bore MR system? Okay. And for those of you that would typically not scan a patient on a vertical bore system if it's not labeled, after hearing my presentation, hopefully you'll now rethink that and change your policy. I want to show you also, since I have the opportunity, that now, even though I was going to kind of confine my statements to passive implants, there is at least one manufacturer, this is Medtronic, that specifically tested and labeled their active implant, and this is the link to insertable cardiac monitor. It's an important device. This is what it looks like. It basically looks like a flash drive. This is an active implant that's been specifically tested and labeled for vertical bore MR systems. And here's the example of the instructions of use for this particular cardiac monitor. Get down to where it says the static magnetic field orientation. It says it's acceptable for a vertical bore system, and there it is in a bold print, perpendicular to the patient, anterior, posterior, perpendicular to the patient, left, right. That includes now the vertical field MR systems. So at least one manufacturer is taking the fact that these vertical field systems are in widespread use, and patients can very much benefit from the utilization of those devices or of those MR systems in the clinical setting, as my colleagues had previously reported to you. So if you have any questions, please feel free to notify me on my website, mrisafety.com. There's a list of thousands of implants that have been tested and labeled for MRI technology use. There's a lot of other safety information there, and my email address is readily available, and feel free to contact me if you have questions. And I want to thank Fujifilm for having a limited number of my textbooks available here after the presentations today. I'll be at the Fujifilm booth. This is a textbook that has a list of 50 plus international authors, 36 chapters, and anything that you could ever imagine in the area of MRI safety has been covered in the 36 chapters of this textbook. Thank you very much for your attention.
Great, thank you very much. Is there one quick question which is burning? I have one. Is there a situation when, are there certain situations where I can expect more trouble with a vertical field in an implant compared to a 1.5 Tesla standard tunnel scanner?
With regard to a passive implant, I can't think of anything, with regard to where it would be worse for a tested and labeled passive implant that's been labeled and tested at 1.5 and or 3 Tesla.
Question to Dr. Aradi. Do you have patients that are sent directly to your center because you have that ability of a low field system with this very good conditions for implants?
Yes, actually, from the yes, yeah, we have a very good reputation in Hungary. People are coming from we are living in the western part, so not so far from here. But they are coming from the eastern corner of Hungary also just to for our low field scanner, also for the comfort sometimes, because despite the 3 Tesla is also a 70 centimeter bore, but also with the implants, and we are a great user of the MRI Safety.com also, so it was an honor to meet Shellock professor. Okay, so yes.
Excellent. Thank you very much. The time is gone, so we will be available at the booth, the 3 speakers here, and for your questions and for discussions, and of course, pick up your copy of his wonderful book. Thank you very much for being with us here today.